blessings. I'm James Sutton. This is Road to Recovery. Today, my special guest is Dr. Abby Morris. For those of you that aren't familiar with Dr. Morris, she's the medical director of IAFF Center of Excellence. She's board certified in psychiatry, neurology, and addiction medicine. She's the medical director of Montgomery County's Overdose Response Program and a medical consultant for the SWAT and CIT team, right?
CIT. Mm-hmm.
CIT, right. So welcome, Dr. Morris.
Thank you very much. It's a pleasure to be here.
Yeah, I know you're busy. You have a lot of things going on, so we're glad that you took time out of your schedule to be with us today.
Well, I appreciate the opportunity. I think that what we're going to talk about is an important topic, and anytime I have a chance to talk about mental health is a good day.
Right. Now, I've been to some of your trainings, and you're a good trainer.
Thank you.
So let's start with trauma, because you're an expert on trauma. A lot of the work that you do at your facility is based on trauma.
It is.
Can you explain to us what is trauma?
Well, it's a complicated topic. So trauma itself, the word trauma comes from the Greek word wound. And so it can be a physical trauma when you get a wound, when something hurts you. But emotional trauma, I think, comes from when the body experiences an emotional stress that it can't integrate, or that overwhelms the brain or overwhelms the body's ability to, like I said, integrate or deal with it. So if somebody goes through a natural disaster or has a car accident or it has experiences some sort of abuse, if the body experiences that in a way that it can't manage it, they can experience it as trauma. So not everybody who has the same event will experience it as traumatic. For instance, if someone jumps off a cliff because they want to dive into the water below, that won't be seen as traumatic. But if someone is pushed off a cliff and they're not expecting that, and they end up in the same water below, that might be seen by them as traumatic. So a lot has to do with interpretation and expectation and the unpredictability of the events that someone goes through.
Oh, okay, great. Now, with the population that you basically work with, you work with a lot of firemen from across North America, Canada, first responders.
Correct. So the IAFF Center of Excellence, IAFF stands for the International Association of FireFighters. And so at my center, we only serve firefighters, dispatchers, paramedics that are part of that union. So I spend all of my days working with first responders, who are basically the tip of the spear when it comes to all kinds of traumatic events. So they experience trauma indirectly and directly through their career, every day, all days of the year.
Okay, so normal person, well, I'm not really normal, but say for instance, if I experience a trauma, is it any different for me who's not a professional and don't do it every day than a person who is actually trained to do that and that's what they chose to do as a career?
Yes and no. So there is some training that firefighters, paramedics, EMTs go through that helps them to manage or develop some resilience, but I'm not sure that any human being could really be prepared for the daily persistent exposure to trauma. So a firefighter isn't just somebody, at least in our country, at least in North America, isn't just somebody who goes into a burning building. Firefighters are called on to for natural disasters, for shooting events, for suicides. They attend to issues that happen at schools and car accidents. And so drownings, suicides. And so the variety of things that they're called on and the amount of stress and the amount of ways that they're asked to deal with stress. So a firefighter in a day might have to see 10 horrific things. And not only the horrific things they see, but the reactions to other people when they see it. So the firefighter might tell me that the trauma that they're dealing with at the center is not the dead baby, but the mother of the dead baby screaming, "Save my baby," is what they hear in their dreams or what they have a flashback to. So the inability to manage or cope or integrate with the grief and the horror and the humanity that they have to deal with. So imagine being a human being who follows every protocol and does everything right, and people still die. That sense of learned helplessness that they have to deal with as well. So they deal with things better because they are aware that they have to see horrible things. But at the same time, the amount of things they have to deal with and the amount of times they deal with it and the amount of times they're told to stuff their emotions because of it, I think causes there to be a accumulated damage.
Accumulated, right. I know we look at that in terms of, the therapists that work in the jail. You can get accumulated stress, accumulated
Yes.
trauma
Yeah.
from serving the population every day and hearing terrible
Yes.
stories every day.
Yes. I say that my firefighters are onions. There's these layers upon layers upon layers upon layers of trauma that they have. And to be honest, most of them have had very traumatic childhoods. And I think it's those traumatic childhoods that leads them to want to be public servants, that leads them to want to live lives bigger than their own, that leads them to want to save the world and be heroes. No one protected them, and they want to save the world. And so I think it starts in childhood, and then they get that accumulated trauma over time. And the technical term is complex trauma.
Say it again.
Complex,
okay.
PTSD or chronic PTSD, or we'll say C-PTSD is the way that we'll look at it in the clinical world.
I see. And how do we respond to trauma normally? What are some of the ways that we respond to those type of events?
So our body responds to it in different ways. In an acute fashion, we have an increase in cortisol, right? We have a fight or flight response so that we can protect ourselves. If something bad's about to happen to us, if someone's about to push us off the cliff, we need to fight or we need to run. So we have this increase in cortisol. We have our body mobilizes that fight or flight response so that we can protect ourselves or protect the people around us or get us out of a situation. But if that response becomes chronic, then we end up with PTSD. So the more trauma, the more stress our body accumulates, we begin to see changes in our brain. So the changes in the brain that we see with PTSD is we see 3 areas of the brain that change. We see the amygdala. The amygdala is the area of our brain that works with fear. We see changes in the hippocampus, which is sort of where our memories are formed and where we have a calendar in our brain. And we see changes in our prefrontal cortex, which is where our emotions are and where we form our ability to organize executive functioning, which is why we see the symptoms we do in PTSD. So when our hippocampus shrinks due to stress, we have the inability to manage time, which is why we have flashbacks and why we have nightmares. We no longer can tell that the fear is in the past. We feel like that fear is now in the present. And so that's that flashback feeling because our hippocampus has become weaker. The amygdala grows in PTSD, which makes us feel fear more often. It's larger and it's giving us signals that we should be fearful now, and it's wrong. And the prefrontal cortex gives us this inability to manage our emotions, which is why we see the symptoms we have in PTSD. So it's really interesting that we can take the symptoms and then bring them back and see the parts of our brain on a PET scan, on a SPECT scan, and know where they come from.
Wow, that's very interesting. I know a lot of times, I haven't had a lot of experience with firefighters in my work in the jail, but a lot of veterans, they always tell me that they had a hard time controlling their impulses. They have impulse control, so they consequently started using drugs and alcohol and terrible nightmares. Some never sleep at all.
That's right.
From being in the wars and confusion. And a lot of them talk about sometimes they forget to pay bills and they just forget what they're doing in terms of organization. So
that's that executive functioning, that prefrontal cortex shrinks of people after they have prolonged trauma. And they have the inability to sort of manage those things as well. And then you have that activation, that sympathetic tone gets really high. And so they have that fight or flight that instead of coming back down, stays really activated.
I see. Okay. Now, that's a little bit off the subject, but you kind of lit me up when you talked about childhood trauma. What about people who've grown up in neighborhoods, like I know you're from Philly, and neighborhoods neighborhoods where there's a lot of gun, violence and a lot of fear because you're not sure, if your children are going to come home safe and or your parents. If a person, would that be considered the kind of childhood trauma that would make a person want to become a police officer or a firefighter or
That's
something?
exactly it. So a lot of the firefighters have had experiences where they had a lot of chaos in childhood. There's a lot of unpredictability, whether it's unpredictability in their neighborhoods or unpredictability in their family life. So perhaps there's parental abuse. Their parents were abusive towards them or neglectful towards them, or they had some sexual abuse, or they were bullied in their childhood, or they grew up in neighborhoods or in situations where they didn't feel safe. And if you don't feel safe, let's say somebody abused you and no one else protected you, then you want to put yourself as an adult in a place where you can feel safe. If you're a firefighter, is anyone going to sexually abuse you? No one's going to touch a firefighter. You're going to be big, going to be seen as big and strong and powerful. And you can protect other people. So you can feel as though you're going to stop that reenactment and you can protect others. You're going to see children and you're going to protect them. And so you're going to see yourself as stopping that cycle of abuse, at least in your life. But unfortunately, what ends up happening is you end up going to a field where you see more trauma, and it's proof to you that the world is unsafe, that people are unsafe, that bad things happen. And that happens with police as well. And like you said, with people in the law enforcement careers and prison goers. And it reinforces this idea that the world is bad, people are bad, you are unsafe, the world is unsafe, and your family is unsafe. And so it can increase that heightened sense of fight or flight and the increased sense of you're unsafe and you need to protect yourself.
Right. Now let me ask you this. In your experience working with firefighters and other people with PTSD, I know a lot of times in addiction, when people have a long history of trauma, they isolate and they don't ask for help.
Right.
They get locked in and into their symptoms and just continue to use drugs and alcohol to treat their symptoms instead of looking for help, unfortunately. So I guess does the union really have an outreach, or how do you find a firefighter that needs help?
Well, I think it's been complicated for firefighters, and I think probably for police as well, because you're in a field where you're supposed to be big and strong. You're supposed to be the hero. You're supposed to be the fixer. And if you need help, then you feel you're stigmatized. You feel like you're going to be seen as weak, that people aren't going to trust you on the truck. People aren't going to trust you in the department. People have that fear that if they come to get help, how are they going to go back and be viewed? So there's a lot of barriers to help. I would say that the union, the IAFF in particular, has been excellent in trying to get this to the forefront. That's how we became the center. They opened a center particularly just for firefighters to say, it's okay to ask for help. PTSD is real. We need to stop the suicides. We need to bring this to the forefront. We need to make it safe for people to ask for help. But in reality, it's always hard for men to ask for help. It's really hard for men in fixing careers to ask for help. It's hard for men who wear a uniform to ask for help because it's stigmatized. And if you say to somebody who's a firefighter, I think you have PTSD, they'll go, oh no, I'm supposed to see these things. I'm supposed to be ready for these things. I'm not weak. People who are veterans, they're okay. They're supposed to have PTSD. They've been bombed. They've been through an IED attack. I'm a firefighter. What I do is part of my career. I shouldn't have trauma. But how do you take human beings, ask them to do superhuman things, and then ask them not to have human reactions like fear, like grief, like sadness? That's what we ask these men and women to do every day. We ask them to do these superhuman things, to see things and experience things that any other human being would find horrific, that we would need to have to process, and ask them to stuff all the emotions and suck it up, buttercup. And it causes a lot of emotional damage.
Right. Now we're going to have to take a little break right here, but I'm so glad that the firefighters have you.
Well, I'm glad to be with them.
Yeah.
Wonderful people.
Yes. And then, my gratitude goes out to the first responders because, especially during the pandemic, they've been out there and, putting their lives, at risk for us. So we're going to take a break right now, and we'll be right back with Dr. Abby Morris.
Okay, Dad. 1, 2, 3. You saved me. Dad?
Are you okay?
I'm fine, dear.
Your hero needs you now, and AARP is here to help. Find the care guides you need at aarp.org/caregiving.
Hi, I'm James Sutton. We're back with Road to Recovery. My guest today is Dr. Abby Morris. So Abby, you were just talking about the first responders, and off camera, you were saying that they're such a wonderful group to work with. Can you repeat that? Because some of the population I work with is hard to work with in the jail.
They are complex. They can be difficult because by the time they get to me, they have spiraled down, but they are amazing, wonderful, kind, sweet, hardworking. Like when they come to treatment because they want the treatment, because they want help, there's no one who works harder than these first responders. My firefighters, they want more information and they want the help. They're just amazing. And they're grateful. When they feel better, when they get better, they're just incredibly grateful for anything you give them that helps them along that way. And so I always find it to be such an honor to be part of their journey.
Right. Thanks for sharing that.
Yeah.
Now, I do a lot of work. As a matter of fact, this program is about reducing stigma toward addictions. And you're actually, addiction medicine qualified or certified. So with the stigma, you were just talking about how, some professions like the police and the firemen like to hold the line and, man up, don't admit when you're, in pain and don't ask for help. What about the stigma of an addiction? When a firefighter treats his PTSD by doing opiates or was injured and got oxys as their prescription and becomes addicted, how does that play out in that profession? Because we know it's always progressive, with people, in general.
Exactly. So our center is dual licensed. We're mental health and addiction. So our firefighters come to us for addiction treatment as well. And so we see quite a bit of addiction. The number one addiction, I would say, is alcohol for firefighters. Secondarily, it's opiates, because they do have on the job injuries, but they also have a lot of anxiety, and opiates erase anxiety. And so it's an incredibly emotionally powerful drug for them as well. And what happens is, I think doctors and society trusts first responders more. So doctors write more prescriptions for first responders. They trust them. They don't see them as being more prone to addiction. But in fact, these are, very action prone, very impulsive, very willing to take risks, right? Who's more willing to take a risk than a firefighter? Who wants to go to that burning building? I'll go. Who wants to try this bill? I'll do it. So they're very prone to taking risks, and so they're very, very prone to also an addictive personality. So they're going to see a lot of addictions, and like you said, having anxiety, having trauma, having difficult childhoods. Typically, a difficult childhood might mean a parent had an addiction or an addiction issue. So genetically, they're coming with some strikes against them. So I think that it's very difficult for a firefighter to say, I have an addiction problem and I need help, because they're using heavy equipment. They're driving the trucks. They have to be trusted, not only by the society, but by their peers, right? If you're going to go into a fire with another person and trust them to save your life, you have to know that they're in good shape mentally and physically. And so a person who has an addiction, who's in that type of role, may not want to tell the person next to them that they're struggling.
Right. Now, how long have you been working with this population? Because my next question is going to be, how is the success rate for first responders in recovery?
So the center opened in March of 2017. I started working a little bit more with police earlier than that, with the CIT and SWAT, but officially with firefighters in 2017. I would say partially because of the population itself, and partially because I think we have a fabulous group of staff and a great curriculum. We have very good outcomes. Like I said, this group works really hard. They're very motivated. They have the support of their union. They have the support of transition. We follow up our patients for up to 18 months when they leave. So they aren't just sort of, okay, you're done, you graduated, bye-bye. We really do try to make sure that they have what they need when they go home, because on campus for 35 days, they're in a bit of a cocoon. Then you go home to all the people and places that were stressors and triggers before. You don't have those on campus, and then you go home and have them again. But I would say that there's still relapse. Relapse is unfortunately part of addiction. And the relapse rate for alcohol and drugs is approximately 50 to 60%. And then it's easy to go, oh, well then, how can we be successful with this? But what the relapse rate for hypertension is similar. And the relapse rate for diabetes is similar. And the relapse rate for asthma is similar. But we don't give up on those populations. When we take our mother to the doctor and her blood pressure is high, we don't go, Mom, how could you? Oh my God, what did you do? We go, okay, Mom, let's lower the sodium in your diet. Let's get you exercising again, and maybe we'll try a different medication this time. We don't tend to stigmatize the other chronic illnesses. We tend to stigmatize the behavioral ones.
Right, unfortunately. And let me ask you this: when they do leave your facility, do you have any kind of alumni or peer support with other firefighters who were treated their injury with Oxycontin or something, and then comes to you, and then you help them on the road to recovery? Can they be an example and hope for some of the newcomer?
Yes, absolutely. So one of the possible silver linings of COVID is this use of Zoom. And although I think, really didn't like AA going to Zoom, and for the most part, people do better with face-to-face AA, for our patients, because they come from all over the country and Canada, when they leave the facility, because now there are Zoom group AAs, they've created their own for the alumni of the facility. So there are now, COE, alumni, AA, and NA groups, and Smart Recovery for that matter. And they can support each other because they know each other, because not only are they firefighters and that similarity, but they're firefighters who have addiction and they have that similarity. And they're firefighters who have addiction who've been at the center. And so there's so many things that tie them together, that band them together as brothers, that really does help. They help each other so much more than they can if they just went down the street to the local church or school. Right. And so there really is that support, and peers and peer support in the fire world, like I think it is also with police, is an incredibly powerful means of recognizing and monitoring and help for fire and paramedics. And that brotherhood is an incredibly powerful tool. They're going to listen to a peer before they're going to listen to a doctor. If I say to them, I think you have a problem, if a peer said to them, I'm worried about you, that's going to be much more meaningful. Right.
Yeah, I've had the same experience because I'm in recovery. When I work in the jail, in our drug program, people automatically trust me, even though I'm certified addiction counselor. They don't trust me because I've been I went to Lincoln. I was up in Philly, right? Yeah. Because I was in the graduate program at Lincoln. They don't care about that. They care that I used to use. And I'm 22 years in recovery. That they like that part, right?
Absolutely.
So peers can be very important part of the workforce.
Absolutely.
And support system. Now we have a few minutes left. I wanted to touch base because you trained me on overdose response, and since you trained me, I've trained about 1,000 people. So you really, impacted Montgomery County by all the people that you've trained that went on and trained others. So thank you so much for, your expertise and taking time away from your facility to come over here to Montgomery County. Because I remember you used to come over and do groups in the evening, and I know you just worked all day long. So thank you so much. So let's talk a little bit about opiate overdose response, because you're the medical director of overdose response program in Montgomery County.
Right.
So what was the goal of the program?
Decreasing death. Decreasing death, decreasing morbidity and mortality. The drugs are out there. people are going to use until we can get our arms wrapped around enough people to get people to not use. We've got to decrease morbidity and mortality of the use. And if people are, if there's something out there that we can do that can help people not to die, it's harm reduction. You know, we want people not to use. That's number one. But if people are going to use, how do we reduce the harm? And Narcan is something that I can use, my son can use. When he went off to college, when my oldest son went off to college, I gave him a Narcan kit. I said, put it in your dorm. Here's how you use it.
Right.
I mean, because the reality is that things might happen. And I don't want him to feel like there was something he could have done, or I felt like I could have done for him to reduce or avoid a death. And so we were doing trainings all over Montgomery County with people who, librarians, right? What's open during the day where people can go that don't have to pay for anything, who might be homeless or using drugs or in need? It'd be libraries, 7-Elevens, fast food restaurants,
Right.
homeless shelters. You know, if somebody came out of treatment and they're going home, somebody should have a Narcan kit. So Narcan is a way to reverse opioid overdoses in people by spraying a medication up their nose and knocking the opioids off the receptor so that somebody who just became unconscious because of opioids can wake back up. And it's a way of mitigating that until people can come from, emergency responders can come, take that person to the hospital and get them the help they need.
Right. And you know, because of COVID, you know, I kind of like, because that became, you know, the presenting problem all over, we kind of forgot about the opiate epidemic, you know, because it's still going on. It's still fentanyl
Yes.
killing people all over the country, and it's not being noticed as much because we're kind of looking at COVID.
Yeah.
So, you know,
It's worse because no one's around to do the Narcan, right? People you were using together. You know, if you're at a party and you use and someone sees you're down, then someone can give you Narcan. Now there's no one to give that person Narcan, so people are dying alone.
right. And also, you know, a lot of the treatment centers and like you said, the AA meetings, the brick and mortar were closed. A lot of the treatment centers had to cut back on their on how many people they could serve because they had to protect the people from infecting each other with COVID. So we've had a lot of challenges during this COVID pandemic in terms of managing the opiate crisis effectively. I think a lot of areas didn't know what to do because they weren't doing outreach. They couldn't put their volunteers on the street because they would put them at risk. So I'm so glad that we did do enough informationals that Narcan does work. It doesn't encourage people to use drugs. It just keeps them alive until they can get the treatment.
Correct.
So I just wanted to touch base on that before we go. We got a couple of minutes left. Is there any thing that you want to leave with the viewers that we didn't touch on or that's important to you?
You know, I think keeping mental health in the conversation. It's okay to talk about having a problem. It's okay to say, I'm struggling. It doesn't show a weakness. The weakness is being alone. If you can engage someone you care about in a conversation about how are you doing, how can I help, you don't have to have all the answers, but if you can help somebody by letting them know you're there and helping them find the answers together, like you said, helping one person, saving one life makes all the difference, you know. And sometimes it's just about being part of the conversation. I think sometimes we're worried if we talk to somebody about asking somebody if they're suicidal might give them the idea about being suicidal. And that's not what happens. Letting somebody know that you're present with them really makes them feel understood and gives them a reason to live. You know, all you need to do is be there present for somebody, and that gives them a reason to live. And I think when somebody is overwhelmed, and we talked about trauma being a sense of emotions overwhelming someone's system. So when you're present with somebody, it's like taking some of the weight off and making someone feel a little less overwhelmed. So being present with somebody makes someone feel less overwhelmed than taking some of that trauma away.
Right. Thank you. Good closing words. Thank you so much for being my guest today with Dr. Abby Morris. Thank you again, Abby. And I will see you on the road to recovery.